midwife from the American College of Nurse Midwives, Sacha James-Conterelli, president of the New York State Association of Licensed Midwives, and Catherine Rood McFadden, MSN, so it's MSN.
I'm a former NICU nurse from SUNY Downstate Medical Center.
There you go. Thank you so much. Thank you for your patience, ladies. Now, as you said, as we've said before, you all are going to speak truthfully. Is that correct?
Yes.
Yes?
Yes.
Ma'am?
Sorry.
Are you going
Yes.
to speak truth? Yes, thank you. Take it away.
Greetings, Chairman Gottfried, Chairman Rivera, and members of the New York State Assembly and Senate Health Committees. Thank you for this opportunity to provide testimony in support of the New York State Health Act.
Excuse me, can you each state your name?
Oh,
for the
I'm
record?
going to.
Yep.
That was my next.
Oh, okay.
My name is Patricia Loftman. I'm a certified nurse midwife and fellow of the American College of Nurse Midwives. I graduated from Columbia University Graduate School of Nursing with a specialty in midwifery in 1981. I practiced full-scope midwifery, caring for women as a midwife, and former director of midwifery service at Harlem Hospital in New York City for 3 decades. Full-scope midwives provide the full range of women's reproductive health care. This encompasses prenatal, labor and delivery and postpartum care, gynecologic care, which includes contraceptive management, and primary care. I retired from clinical midwifery in 2010. I was a midwife at Harlem Hospital when the community was ravaged with the crack and HIV epidemics beginning in 1984. For 10 years between 1985 and 1995, I, together with another midwife, cared for women whose pregnancies were complicated by drug use and HIV infection in a special clinic designed specifically for them. They should not have had good outcomes, but they did. And what was the reason for that? The women attended clinic weekly, which was a requirement, and adhered to multiple and varied appointments. They were engaged in their health care because they were cared by midwives who looked like them, who understood their cultural and linguistic norms and values, with whom they developed a relationship and trusted. They remained engaged in their in the healthcare system post-delivery, continuing to adhere to health maintenance activities. Recently, an unprecedented amount of media attention has centered around the crises of Black maternal morbidity and mortality. Today, Black women are 8 times more likely to experience a pregnancy-related death than a white woman in New York City. Approximately half of the causes of these deaths are of medical causation. Yet a study of more than 45,000 women found that only more than half visit their OBGYN. Less than 6% visited a primary care physician. The CDC reported in 2017 that 12.5% of women aged 18 and over reported that they were in fair or good health. Women, however, only 9.5% of women under age 65 are reported to have health insurance coverage. Women can't take control of their health without health insurance. The New York Health Act would expand women's access to health care by eliminating the lack of insurance as a barrier to visiting a primary care provider to engage in health screening, disease prevention, and health promotion activities before they enter pregnancy. Most women enter the healthcare system through pregnancy. However, at the end of that pregnancy, women's continued access to primary health is discontinued when their health insurance coverage ends. Women's health care has historically been neglected by the healthcare system outside of the maternity cycle. The New York Health Act would make women's health, including care for postmenopausal women, who represent a large number of women without health insurance coverage, a priority, and enable women to access primary care providers, including midwives, to maximize their health and well-being going forward, and if desired, enter their next pregnancy healthy, thereby improving their pregnancy outcomes and preventing pregnancy-related deaths and pregnancy-related near deaths. More and more women of color who are the consumers of women's reproductive health care in public hospital systems where most midwives work are asking for midwifery care and midwives who look like them. The New York Health Act would expand women's access to midwives. Midwives are experts in holistic health care with vast experience across all birth settings, from home birth and birth center to large tertiary academic medical centers. At a time when abortion services is under threat, midwives were included in the New York State Reproductive Health Act, which codified roe protections into New York state law. Substantial evidence exists that documents the benefits to all women of midwifery care, and I have included in my statement evidence from journals such as The Lancet, the Cochrane Review, and PLOS1, or the Public Library of Science. In summary, the New York Health Act would increase health equity for women and families, enabling them to address issues of reproductive justice, birth equity, health disparities, maternal and infant morbidity and mortality, and primary care through increased access to midwives at a time when hospitals are closing their maternity services in rural areas and the availability of women's reproductive health care providers are decreasing, and I thank you.
Thank you.
Chairman Rivera, Chairman Gottfried, members of the Senate and Assembly Health Committees, thank you for taking the time to listen to our testimony today. My name is Katie McFadden. I'm a registered nurse certified in neonatal intensive care. Last month, I resigned from my position as a staff nurse in the neonatal intensive care unit at SUNY Downstate Medical Center in East Flatbush, Brooklyn, where 90% of patients are of African descent. In the 5 years I worked for Downstate, I cared for many patients who died or suffered permanently worse outcomes for conditions we know how, but did not have the resources to optimally manage and treat. I frequently worked shifts with half the nurses we would have needed to meet national safety standards. Even when we managed to get through these shifts without major medical errors, which were common and are common, our fragile patients still suffered. Babies do not cry while they're in the womb. And when they're in the NICU and only receive a fraction of the care that they need, prolonged cry times create a toxic level of stress hormones that forever changes the way their brain forms. Working in an under-resourced NICU, I could literally hear my patients' neurodevelopmental potential diminish as I focused on higher priority and life-sustaining care. Downstate's NICU also lacks a lactation consultant, physical and occupational therapists, mental health services for parents, a developmental care specialist, a peer support and volunteer coordinator, and a dedicated nurse educator. Services NICU babies need not just to thrive, but simply survive. Some of these absences were in direct violation of state regulations. All are considered standards by relevant professional organizations and are common in other level 4 NICUs. Less than 10 miles from predominantly white-serving private hospitals, conditions at Downstate are worlds away, and it shows an exponentially worse hospital and population-level outcomes. In 1850, our Constitution counted most Black people as 3/5 a person, and the white-Black infant mortality rate was 1 to 1.5. In 2019, the public insurance covering the majority of Black birthing people pays half as much for obstetric care as the private insurance covering the majority of white birthing people. And the white-Black infant mortality rate is worse at 1 to 2 to 3. The largest single driving force behind racial disparities in maternal infant health outcomes in New York City is the lower quality of care provided at a concentrated set of minority-serving hospitals. Quality is worse because staff and services are missing. Staff and services are missing because we cannot afford them. We cannot afford them because reimbursement from public insurance are considerably less than the true cost of care, and we care for a disproportionate amount of patients on public insurance because of historic and ongoing racial segregation and economic disenfranchisement. Even in neighborhoods with better funded and safer private hospitals, widespread, illegal, yet unchallenged insurance discrimination causes de facto racial segregation. We've never stopped having racial health disparities in this nation because we've never started valuing the lives of all people equally. A single-payer system eliminates the funding disparities that drive the racial disparities in New York. It eliminates the burden of underinsurance and high out-of-pocket costs that make necessary, quality care still out of reach for birthing people and their families. For this and for all of the reasons presented before you today, I urge you to pass the New York Health Act. Thank you for your time.
Greetings, Chairman Gottfried and Chairman Rivera, and members of the State and Senate. It's my pleasure to provide you with my testimony. My name is Sacha James-Conterelli. I've been a midwife in New York State for over 18 years. I proudly represent the 1,200 midwives as the president of the New York State Association of Licensed Midwives. As the president of the New York State Association of Licensed Midwives, we've offered our letter of support, and I would like that to be accepted as part of my testimony. As one of the co-chairs of the Governor's Task Force on Maternal Mortality and Racial Disparities, we learned from our listening sessions across the state that women and birthing families in New York are in desperate need of health care resources. The lack of resources has resulted in little to no care options, contributing to our rising rate of maternal mortality. Maternal mortality and morbidity is a direct reflection of the health of a community. How does lack of insurance affect access to care? Health insurance makes a difference in whether and when people get necessary medical care, where they get their care, and ultimately how healthy they are. Uninsured people are far more likely than those with insurance to postpone health care or to forgo it altogether. Going without health care for a pregnant woman has dire consequences, not only for the pregnant mother, for the growth and development of a child. Our community, New York State, is unhealthy. We have an opportunity to begin to address this through the New York Health Act. And so for many of the others that have already spoken before me, please pass the New York Health Act.
Thank you so much. Senator Prasad.
Thank you, Mr. Chairman. I just have a couple of questions I'd like to ask you. How do you see the New York Health Act changing the mindset in the communities you're talking about?
I tried to document in my testimony the experience that we had at Harlem Hospital. These women were considered very, very difficult to reach, and yet still we were able to reach them. And we used that as a pilot for everything that we did after that. I think it's very important that women receive care from people who they feel that they can develop a relationship with, and that was the foundation for that program. So I think for all of those reasons, the New York Health Care Act would enable women to access those kinds of services and enable them to improve the quality of their health.
Don't you also think we have to start a new education campaign in terms of getting women to understand the importance of seeing a physician and going to the services that you're talking about?
Well, I think women already know that, but as we've heard before, they're making all different types of choices. Fortunately for women who access public health system, most of those women already have Medicaid. But I also worked in a federally FHQC, and those women did not, and they were making choices between whether they paid their rent, whether they paid their medicines. So it depends on who the payer is. Many of those women not only are not insured, many have insurance, but they are underinsured. And so just in terms of accessing just basic health promotion activities, making certain that they got their mammograms, making certain that they got their bones, the DEXAs, those kinds of things women make choices about that not necessarily facilitates them in having, the maximum health that they could have.
Some of the hospitals that you mentioned and some in the surrounding areas, they have been trying to do that, and that's why I talk about the education, and trying to get the women to come in. It's the hardest thing to do, and so we still have to do some education. You're talking access to health care. You're putting out there the mammogram buses. You're going into these communities, but the women are still, they don't have to pay for it, but they're still not coming out. What do we have to do?
It's a trust issue. It's a trust issue.
So it's still about de-educating them again. And we're talking, they're not seeing the people of color coming into the communities? If you have the organizations, what do you have in place to go into those communities to ensure that women are seeing people like themselves, so who are going to encourage them to come out? What are you?
So I'd like to speak to that, and the task force on maternal mortality and racial disparities that was from the governor. One of the things that we did learn in the listening sessions all the way from Brooklyn to upstate is that women they do not know that we exist as midwives. So one of the things that we do in many of the hospitals is we go out into the community and we are educating the women. But if they don't have access to us because there's a hindrance from their insurance to see us, and we're in their communities, we're at their community board meetings, we're at their schools, we're providing education to the youth and to also the teachers in the public school system, and they want to access us, but they don't have an insurance that will allow them to see a midwife, and they've already established a relationship with us, then that hinders access to care. And then if there is a trust issue with their providers in their community that may never come out of their hospital or their private office and go into the community and get to know the community and become educated about the community, then they're not going to seek health care from them either.
I cover a district where what you're talking about doesn't happen. Part of my district, the midwives and the doulas and all, they're not going to my community boards in certain parts of my district to tell them. And that, the area is like the epicenter for the issues that we're talking about. So what do we do to rectify that? Just passing the Health Act is not going to change that. We have to be out there, and we're not doing that. We're not doing enough. And so my charge is for asking you to ensure that you are coming out to the community. That particular, Brownsville, East New York, I've been to your meetings. I've gone, we've sat in a room and spoken about it, but there's no follow-up for that particular community. So we have to do a better job of that.
I totally
and the last
agree.
thing, Assemblymember Szilagyi and I are looking to make sure, the governor is talking about the coverage for midwifery. We're also making sure there's a coverage for doulas, so the conversation is out there.
I think one of the things that we also found, the governor held a listening tour for women across New York State, and one of the things women talked about was receiving respectful maternity care. But I would like to really emphasize that clinic that we had in Harlem during that decade, the women was our best advertisement. The women in that clinic talked about the respectful care that they received, and they came. And I think, if nothing more, I'd like to just enforce that message. These hard-to-reach women came, and they spread the word.
Okay, thank you.
Thank you.
Work and for your continued work on behalf of Black mothers everywhere. So we will continue to work, because this is actually something that's. I was looking at I'm sure that you were here earlier. There was a graph that showed the seriousness of this in the state, and certainly know that many of us have that in our minds when we're thinking about working on passing this. Thank you so much for your work, ladies.
Thank you very much.
Can I say one more thing?
A quick point, yes, because we still have a few
Just
folks to go.
throughout the day, people have talked about, if we pass the New York Health Act, we'll have to ration care. We're already rationing care.
Yep.
It's just that when I have 3 babies and they all require 8 hours of care on a 12-hour shift, that means I have to decide what half of the care they're not going to receive that shift. And then, if I'm honest about it, I may lose my license and my job. So I think we need to stop thinking about, oh, we're going to be rationing care. We are rationing care, it's just that Black people have gotten the short end of the stick. So if we're worried about rationing care, it can't only be when white people may be affected.
Thank you, ma'am.
Thank you.
Thank you for that. Next, we're almost there.